Doutor Henrique, pode começar.
Ok. Bom dia a todos. Queria parabenizar o Henrique Limacoto por um evento que já se tornou tradicional no nosso calendário. Realmente ele é muito bom. Tem a égide de trazer conhecimento de outros colegas de outros centros, que eu acho isso fundamental, e tenho certeza que o segundo bloco vai ser muito bom. Nós temos o segundo bloco, nós temos duas aulas. A da doutora Júlia Campos Herrero, chefe corporativo de mama do Hospital de Vera Saúde, Espanha, falando sobre as vantagens e desvantagens da mamografia contrastada no estadiamento do câncer de mama. E o doutor Ritse Mann, radiologista do Estudo de Câncer dos Países Baixos, membro da diretoria executiva da EUSOB e membro do comitê científico editorial de radiologia e da família do European Radiology. Para comentar essas duas magníficas apresentações, nós temos o professor Rodrigo Pepe, mastologista da Oncologia Clínicas, da Oncoclínica de Brasília, intervencionista da Clínica de Mama e vice-presidente da Sociedade Brasileira de Mastologia. A doutora Thaís Paiva Moraes, médica mastologista da Rede Mater Dei e da Rede Mama, membro da Comissão Nacional de Mamografia e membro da Comissão Nacional de Especialidades em Imaginologia Mamária. E a doutora Maria Julia Gregorio Calas, presidente da Sociedade Brasileira de Mastologia da Regional do Rio de Janeiro, onde, aliás, faz um belíssimo trabalho, mestre e doutora em Radiologia Mamária pela UFRJ e professora de Saúde da Mulher da Faculdade Estácio de Sá, em Domédio. Bom, com vocês, então, a nossa primeira palestra, que será da doutora Júlia Campos Herrero, sobre vantagens e desvantagens da mamografia contrastada no estadiamento do câncer de mama.
Hello, everyone. Julia Campos Herrero from Spain. I would like to thank Dr. Henrique Limacoto for his invitation to this wonderful Congress, and I would like to talk to you about the advantages and disadvantages of contrast-enhanced mammography in breast cancer staging. We know that the current indications for contrast-enhanced mammography are mainly all indications for breast MRI in patients who cannot undergo a breast MRI, surveillance in patients with a personal history of breast cancer, response evaluation to neoadjuvant treatment, viral spore lesions, and of course, breast cancer staging. We know that contrast-enhanced mammography is mainly more accessible. It is better accepted by the patients. It is easier to interpret. It is faster also to perform and interpret. And it has a smaller learning curve and less costs than MRI. It also has less movement artifacts and less contraindications. But of course, we cannot say that both techniques are identical. In this very last meta-analysis published this year, the diagnostic odds ratio means the overall diagnostic performance of breast MRI is higher than that of contrast-enhanced mammography. This means that the likelihood of a correct diagnosis of a true breast cancer is 123 times to 80 if MRI indicates a positive result compared to CM. Also, the positive likelihood ratio, they are similar in both techniques. That means in patients with breast cancer compared to those without the disease, they have an approximately 4-fold higher chance of being disease positive on MRI or CM. There is a slight difference in the negative likelihood ratio. It means that if the result is negative, the probability that the patient has breast cancer is approximately 3% for MRI and 5% for CEM. Nevertheless, there are some clinical advantages and disadvantages that we will review with some practical cases. For instance, the first one would be patients with a contraindication for breast MRI. Here we have an 86-year-old patient unable to lie prone and pacemaker carrier, but with a good quality of life. Why shouldn't we give her a good contrast imaging technique? In this patient, we had a papillary cancer in the right breast, but there was also a non-mass enhancement in the left breast, sorry, that turned out to be intermediate grade DCIS, which was biopsied by vacuum-assisted ultrasound. Movement in breast MRI is a fairly common incidence. Here we have a patient whose MRI was actually non-diagnostic due to movement. In this patient, there was a distortion in the right breast, which turned out to be a unifocal enhancement in CEM, and it was actually a DCIS with no other additional lesions. Even though the breast was fairly dense, we could confidently say that there was nothing more than this unifocal lesion. One-stop shop means that we can upfront, if we do CEM in patients with suspicious of breast cancer, we can do the CEM, we could do additional biopsies. If we see additional lesions, we can mark them and use MRI if we want or not, just to make sure that we have targeted all the important lesions, thereby decreasing waiting times and avoiding second look ultrasound. It has been proven that not in a lot of patients, but specifically in this publication here with more than 300 patients, that the sensitivity and especially the negative predictive value of CEM in virus 4 lesions are quite high, almost 100%. In this patient, we had a cancer in the right breast, but we did an upfront CEM and we found a suspicious non-mass enhancement, which we targeted and biopsied, and it turned out to be an additional DCIS. Here you can see the comparison with breast MRI. In this case, it was a HER2-positive breast cancer, multicentric, and this is the corresponding tumoral map, which we usually draw to help not only surgeons, but also pathologists when doing the radiopathological correlation. In some cases, we have found some higher specificity, specifically when we see additional non-mass enhancement and in MRI, which is not seen in CEM, and these turn out to be mainly B3 lesions. We have a luminal B breast cancer, unifocal breast cancer, which in CEM, an additional suspicious non-mass enhancement, which we targeted with vacuum-assisted biopsy, ultrasound guided, and it turned out to be a B2 lesion. In this case, CEM was more specific than MRI. It has been published in this series of almost 100 patients that MRI depicted as almost twice as many additional suspicious lesions compared to CEM or molecular breast imaging without depicting some additional malignancies. In this case, the predictive value of additional biopsies was lower for MRI than for CEM. And we have microclassifications. The fact that we have CEM can give us a better idea of if these microclassifications enhance or not. In this case, we have microclassifications which were new. This was over time in 2021. And as we can see here, we not only see the enhancement associated with the microclassifications in CEM, they can see as black dots, but we can see a huge, multifocal extensive enhancement in the corresponding anatomical lobule. Here we can have a closer look at the enhancement in CEM. In this case, surgery proved that it was a DCIS. There are also disadvantages associated with CEM. We know it is not a perfect technique, mainly due to anatomical coverage, and this means that posterior and deep location lesions might not be shown on CEM. In this case, we can see a cancer which was associated with retraction of the nipple areolar complex, and as we can see, CEM missed these very posteriorly located lesions, which turned out to be also luminal A breast cancer not depicted with CEM. This is the corresponding tumoral map. In this other case, we can see that the OML view show us there is a fairly good correspondence between the MRI image and the CEM image, but in the craniocaudal view, we can just, there's not such a good correlation. So posterior and deeply located lesions might not be shown on CEM. This is, in my opinion, one of the greatest disadvantages. Also, low enhancement of certain lesions, which can also happen in MRI, but we have noticed that in CM it is more obvious. Here we can see a very subtle enhancement in the left breast compared to the right breast. There is a moderate BPE, background parenchymal enhancement. In this case, when we compare the MRI to the CM, we can see that there is better contrast to noise and also signal to noise ratio in MRI compared to CM. Here we can see the lateral view in which we can see the distribution of this multicentric lobular breast cancer much better in MRI than in CM. And here we see a nodule in 2D, which is not so conspicuous on CM because it has a higher rate of mucin compared to the ultrasound image. And of course, if it has this mucinous cancer has a higher rate of mucin, a high rate of mucin, not all the cancer will enhance. Here we can see an asymmetrical lesion in the left breast, in the right breast. In this case, this lesion was palpable and was seen in ultrasound. In this case, if we look at the CM, there is really no enhancement that shows up very nicely in the CM. If we compare this lesion, this CM, to MRI, we can see that MRI depicts not only this lesion here, but also more anteriorly located lesions, which turned out to be a grade 3 DCIS and was very hard to see, honestly, on CEM, although you can see it in the 2D as an asymmetric density. When we have an inflammatory carcinoma, as in this case, unfortunately, CM will not show enhancement of the skin, and we will not be calling it so easily possible inflammatory carcinoma. When we compare this case to the images of the breast MRI, we can see how breast MRI depicts very nicely the additional nodules in the skin due to lymphangitic spread of this inflammatory carcinoma. When we have high BPE, also MRI characterizes the lesions better with parametric maps, as in this case, where not only when we cannot see very well this posteriorly located triple negative cancer, which was, it was a luminal A breast cancer, which was the original cancer, but also there is, although there is a slightly asymmetric non-mass enhancement in the right breast, it is with parametric images in MRI where we can see very nicely the difference between the diseased, this was a lobular breast cancer, the diseased area compared to the normal tissue. In certain lymph node regions, internal mammary, supraclavicular, with axilla, which has a high content of fat, it will be difficult also to detect these lymph nodes. And also, there is worse correlation with multifocal lesions. In this case, where we see only one lesion in 2D, in contrast-enhanced mammography, we see the lesion and a high or moderately high BPE, and we see nothing else. When we compare this to the MRI, we can see that there is a non-mass enhancement in the anatomical lobule which turned out to be, it is much better depicted with MRI, and it turned out to be an additional DCIS, which was targeted with clips and treated with breast conserving surgery. Also, breast positioning and air trapping sometimes can give us problems. In this case, we have many causes. First of all, the scar. This is the skin fold of the scar. Also, we have here a false image due to not good breast positioning. And we also have a skin fold here, which can hide some cancers, as in this case, where we see the cancer very well with 2D, but not so easily with contrast-enhanced mammography due to this air trapping. Also, in breast implants, it will be difficult for us. It is actually an indication to perform MRI, because if we cannot perform the Eklund technique, it will be difficult for us to rule out lesions. Here, we could do the Eklund technique, but as in this case, it was very, very difficult to see the additional multifocal cancer. In summary, with MRI, we can do 3D multiparametric imaging. CEM is a 2D non-multiparametric image. We have a higher sensitivity, although we have a high sensitivity with MRI and also with CEM. The meta-analysis show that the performance, diagnostic performance, is higher with MRI. Specificity is acceptable, good in both techniques. We have more contraindications with MRI than with CEM. We can have a problem of gadolinium deposition, although it has not been clinically proven with MRI. We don't need compression, but we need to have the patient in prone position for 20 or 30 minutes. It is easier to interpret CEM. We could have more data with MRI. There is no radiation exposure with MRI. Post-processing is more complex, but of course we have more data. We do not have diffusion. With CEM, skin enhancement, as said, is visible. More anatomic coverage with MRI. Movement artifacts are common and difficult to avoid. Cost is lower and cost is higher with this is changed. It's higher with MRI and lower with CEM. And of course, the IFC systems are less available with CEM. In all, contrast-enhanced mammography is a very good technique. Although MRI is the technique of choice in breast cancer staging, it is very practical to have CEM in cases where MRI is not available. In BI-RADS 4 and 5 lesions, one-stop shop with CEM avoids delays. We are currently doing this, and it is important also to take into account the limitations of CEM. Thank you very much. In case you are interested, I invite you to follow, although in Spanish, the contrast enhanced mammography online course by the Spanish Society of Breast Imaging. Thank you very much.
Hi, my name is Ritse Mann, and I was asked to talk to you about how to use MR for women with dense breast. And I think over the years, the importance of breast MR for evaluating women with dense breast has gradually increased. Let's start with the very basics, right? We're talking breast density, and the question is obviously, what actually is that? Obviously, the fibroglandular tissue that is within the breast produces white areas on a mammogram. The fatty tissue gives you the black areas. Then you have the Cooper's ligaments and the ducts and so on that are actually also white, and that are together the fibroglandular tissue and the stuff that makes the breast dense. So the more fibroglandular tissue is there, and we tend to classify radiology classification or BI-RADS classification from BI-RADS category D. D would be an extremely dense breast, whereas C is heterogeneously dense, B is scattered fibroglandular tissue, and in A, the breast is almost entirely composed out tissue. Obviously, if you the breast is being missed. That is due to the simple fact that all cancers of mamma are equally white as the fibroglandular tissue. Sometimes, obviously, density is a little bit higher, but most of the time they can just hide perfectly well in the fibroglandular tissue. And you see from these images also that the four category level is a little bit artificial, right? There's many in-betweens between extremely dense and heterogeneously dense, and between entirely fatty fibroglandular tissue, roughly in the category over here. And what you should realize, the risk of getting breast cancer also increases in this direction. Besides, the radiation risk of mammography increases a little bit, although that has more to do with breast thickness than with breast density. So if you go into breast cancer staging, which is, I would say, roughly half of our work, right? Then the mammogram in general is our very first imaging test. And that look like this one are sort of hard to interpret. There's obviously cancer here, but the first question would be on what side is it actually, because it's very difficult to see. For those of you who are wondering, it's on the right side. If you look in the right breast with ultrasound, you'll find yourself the cancer, and you can actually measure that, so you can stage this, and this would be a T2 cancer, right? And you have a look at the axilla, and you will find there are lymph nodes with a focal cortical thickening. So according to TNM, you'll get to something like a T2 cancer, right? 2.5 centimeters, and one positive lymph node, which would be CN1. Question is that real? And is that all you need to know when you stage cancers? It seems to be real. It's very likely also the biggest mass. However, if you look a little bit better, then you will see that that's not the entire story of the case, right? This is what we knew. This is something that we found out later, and also this was not known. So the extent of a tumor is roughly 6.2 centimeters rather than the 2.5. That doesn't change the TNM staging, but it provides you with very important data for eventual treatment. And as such, I think that TNM is nice to have. But if you do breast cancer staging, you talk to your surgeons and oncologists, there's a lot more to staging than just a TNM classification. Basically, these are the major benefits of MR. You have accurate size estimation of the primary tumor. You also detect ipsilateral, multifocal, and multicentric disease, and you detect contralateral occult cancers. Obviously, in a case like this one, you can well imagine that there might be cancer hidden in the dense fibroglandular tissue on the left breast. The MR, however, is on that side completely negative. So with that in mind, you can sort of rule out the presence of contralateral cancer, and for patients that's a very reassuring feeling. However, at the same time, in roughly 3 to 4% of patients, you will find occult contralateral cancer. Give you another case, actually not that dense. I would say this is scattered to heterogeneously dense breast. There are calcifications in this breast. You can see that well here in the magnification. Obviously, you do stereo biopsy and these kind of things, right? It's very difficult to find on ultrasound. So you get your calcifications in the specimen, and you know that you are at the right spot, and then it comes back as a HER2 positive cancer. Make an MR, and this cancer is a lot bigger than originally thought, right? This is pure non-mass enhancement, but this is actually a T3 tumor. Obviously, it's a very diffuse tumor, very difficult to see with other imaging modalities, but on a contrast-enhanced scan, even in a not too dense breast, these cancers can be completely hidden. So another example, in this case, in DCS, where you clearly see that the calcifications are apparently in the upper outer quadrant, and that seems to be everything. But if you look at the MR, it's definitely not, right? The entire fibroglandular tissue in this breast is almost filled with the DCS that is actually mammographically completely occult. And you should realize that only about 25% of all calcifications really do calcify, or DCAS lesions really do calcify, and the remainder 75% consequently doesn't. And if you want to look for more disease, if you tend to do surgery on a patient like this, it's definitely a good idea to do some sort of contrast enhanced imaging, and MRs as good as it gets currently. Then if you look at all kinds of different imaging modalities, you get to see that MR techniques, both and in specificity. So you quite clearly have here a very good reason to use MR in women with extremely dense breast or with dense breast in general, if you feel insecure about the actual extent of disease, as well as when you want to know whether or not there are contralateral foci of disease. Next thing that we need to discuss is screening, obviously. Right? A screening exam can look like this, and in this mammogram, finding a cancer is relatively simple, at least for a trained eye. However, you can try the same with this one, and it actually will be a lot harder. I guess you still have found the cancer that's also here in the right breast, but it's not that easy, to say the least. In this case, there is a screen-detected cancer, and I give you this image for a while just to ask yourself whether the cancer is actually on the left or the right breast. Once again, heterogeneously dense. This is, I would never call this extremely dense, but still it's not an easy image to evaluate. And MR basically makes your life easy. The cancer is quite obvious in the back of the fibroglandular tissue in the left breast. MR for screening has been around for quite some time. All the big studies were performed in the beginning of this century. And in 2007, the American Cancer Society released their guidelines for the use of breast MR as an adjunct to mammography. And from that time onwards, MR has been a real screening modality. Right, it was recommended for women with extremely high life that has been supplemented with all other stuff. But it was also advocated for women with a lifetime risk of 20 to 25% or greater. All the studies that before actually included these patients and showed that MR outperforms mammography by a factor of 2, more or less. What was not recommended was to use MR screening in women with heterogeneously or extremely dense breast on mammography. A different population, right? It's not likely, does not really reach to 20 to 25%, and as a consequence, this population was excluded. Nonetheless, if you look at the population that were included, there's a lot of data there that basically says that the sensitivity of MR is 80 to 90%, maybe even a bit more. Specificities are actually really high. And this is real-life data right here, 20,000 MR screens. 280 screen-detected cancers. This is quite substantial, and it actually shows that this really works. Then we get back to the population with extremely dense breast that was apparently not in this population that I just showed you. And in the Netherlands, we did a randomized controlled trial to evaluate the value of MR in these specific women. This is the major fetish paper. Read this graph and you basically understand every 1,000 women were randomized in this trial. However, 32,000 were in the control arm and were not even informed that they were in the trial. Right? 8,000 were assigned to the MR group and then invited for MR screening. Roughly 50% or 60% of those actually wanted to participate in a trial and said, okay, let's do this MR screening. And 1,000 women, 80 cancers were detected. Up there, it's not the 16.5 other, it is here. This shows that the interval cancers in the women with extremely dense breast tissue reduced by roughly 85% if you screen them with MR compared to mammography. Right, you see that women that were invited for MR but did not want to participate in the study actually have interval cancer rate that's exactly the same as the women that were in the control arm. So it's a real reduction of interval cancers, and that implies that this is not overdiagnosis. You also see that back in the second round of the dense trial, where the incidence of cancer actually dropped to numbers that we also know from mammography screening. It went back to 6 per 1,000 instead of 16.5 per 1,000. Also good to know that the false positive rate went to 2.5% more or less, which is actually exactly the same as we observe in mammography screening. So it doesn't lead to more false positives, but it does lead to a lot more and a lot earlier detection of cancers in the breast. The good thing is that if you look at cancer stage in these patients, all cancers detected are node negative and they're all early stage, which basically means that within this population, you will hardly see any breast cancer related mortality. Then if you look at the breast MR protocol, you basically see that there is a lot of sequences in there, but screening is basically here, right? It's the T1 pre-contrast, the T1 post-contrast, and the ultra-fast images in between. Why? Because it's actually that easy. What you need to have is an image like this, where you can clearly appreciate whether or not there are lesions in the breast. And if you are unsure about this, the ultra-fast images might actually help. You can just look whether there's something that comes up as a light bulb. The light bulb effect really is important here. And you get to see here that there's a small cancer in the back of the right breast. And if you realize this, then you see how fast evaluation of MRs for screening purposes can go. Quite recently, the New York group showed that doing a high temporal, high spatial resolution protocol, the red one here, really improves the cancer detection, especially in women with extremely high or moderately high background parenchyma enhancement. Obviously not unexpected. A lot of background parenchyma enhancement might obscure small cancers. And if you use this ultra-fast or fast protocols as were used in this study, then you actually find just a bit more cancers and you find them earlier. Christiane Kuhl and Christopher Comstock did an abbreviated breast MR screening trial on women with heterogeneously and extremely dense breast. And they basically showed that an abbreviated protocol finds about double the amount of cancers detected with DBT as a full diagnostic protocol. In other words, using a very short MR protocol basically is as good as a long protocol. Can we pay for that? Well, the obvious answer is yes. If you look at this graph, this is a so-called efficiency frontier. And we found that if you offer these women one MR every 4 years, you might save roughly 8 lives per 1,000 women screened at a cost of roughly 75,000 euros per life, which comes down to 11,500 euros per quality adjusted life year gained. And that is, according to European standards at least, a bargain. This is a different model, but it comes down to the same. It's now in US dollars. And they say if you do MR screening, then you save one quality adjusted life year for roughly 13,500 US dollars. And if you do abbreviated MR and you are capable of offering MR for a price of roughly $260, MR screening actually is more cost effective than implementing tomosynthesis in screening. Okay, based upon this kind of evidence, we basically wrote a guideline on behalf of the European Society of Breast Imaging. Within that guideline, we state that it is now about time we actually see huge implications. We also recommend that supplemental screening is recommended in women with extremely dense, right, which means that you should offer them something else, and something else is in essence MR, due to the simple fact that's the only thing where we have really good evidence. Ultrasound would be an alternative. There is some evidence that it also reduces interval cancers, but MR is much better. The ACR quite recently also followed, and they basically stated more or less the same. In women with higher than average risk and women with dense breast, you should offer MR, right? If you cannot do that, you might consider contrast enhanced mammography or ultrasound. However, the evidence there is a lot less. And I'm more than happy to have seen quite recently in Brazil, the recommendations have shifted and now actually recommended to offer breast MR to women with extremely dense breast, also guidelines. With that in mind, I think the importance of breast MR for women with extremely dense and dense breasts will only increase. And you will see a lot more of this in the years to come. That's it. Thank you for your attention. And if you have any questions, then I'm obviously happy to answer.
Bom, excelentes palestras, tanto da doutora Júlia como da doutora Mann. E eu queria, então, iniciar agora com os comentários, inicialmente chamando a doutora Thaís Paiva para começar os trabalhos.
Bom dia, Pasqualette. Bom dia a todo mundo. Primeiramente, gostaria de agradecê-los, né, a comissão organizadora, pelo convite de estar aqui entre experts, né? Muito bom esse congresso, realmente, o Pasqualette falou no início, ele entrou para o nosso calendário e é realmente vanguardista, né? A gente vem discutir o que está no mais falado aí para a gente poder aprender um pouco mais sobre diagnóstico e tratamento do câncer de mama. Primeiramente, eu gostaria de perguntar à doutora Júlia se existe, na realidade dela, algum grupo específico de pacientes que ela vai privilegiar com mamografia contrastada. Se existe esse grupo e quem são essas mulheres?
Certainly, there is a group in which we are doing breast cancer screening with contrast-enhanced mammography, and this is patients with a history of breast cancer. We offer it to all of our patients. We have been doing this for 4 years now, roughly, almost, and we are analyzing the data, and the data are really surprising. So as you can expect, we're not finding a lot of recurrences, but we do find very small recurrences, like less than a centimeter, 5 millimeters. And also, we have also found that the negative predictive value is fairly high. When you take into account that a mammography in a patient that has had a breast conserving surgery is only 63% sensitive to find a breast cancer, I mean, you really need contrast. Although I must say, first of all, let me tell you that I completely agree with Ritse in that breast MRI is the best technique to stage breast cancer patients. But of course, if you don't have breast MRI, contrast-enhanced mammography, with all the limitations I just told you, and advantages, is a great technique if you really know how to use it well.
Muito obrigada, doutora Júlia. E agora eu gostaria de fazer a minha pergunta para o doutor Ritse Mann. Na experiência dele, na verdade, duas perguntas. Para paciente com mama densa, ele intercala o rastreamento de ressonância com mamografia, ou a gente faz os dois anualmente? E a segunda questão sobre pré-operatório, se você detecta um câncer numa mulher com a mama densa na mamografia, a ressonância magnética vai fazer parte do seu planejamento terapêutico em todos os casos?
Okay, let's start with the screening question then. I guess that implementing MR in screening is really a challenge, right? What we've seen so far is that the importance of mammography next to MR has gradually reduced. Originally, we used MR screening only in the very high-risk population, and then from the age of 30, we did annual both MR and mammography. Currently, in that population, we start mammography at the age of 40, still starting MR at 25, and doing biannual mammography, so only once every 2 years. If you look in the population with very dense breasts, all cost-effective models basically state that if you do MR screening, it's MR screening alone, without any mammography. That is due to the fact that you might miss an incidental cancer, right? Don't get me wrong. If you do MR and mammography, you will find a few more cancers. But the types of cancer that you find with mammography on top of what you find with MR are mostly low-grade DCAS lesions.
Yes.
And from all evaluations, that's simply not cost-effective enough to pursue finding those, let alone that we might actually harm women by trying to find those a little bit. We're unsure about the latter part of it, right? But it's something to keep in the back of your mind. Cost-effectiveness models tell you don't do mammography at all. Mm-hmm. If you're uneasy with that, don't do it both every year, because that really makes no sense. You do the mammography to find lesions that grow slowly. Mm-hmm. So if the mammo is negative on year 1, it will be negative in year 2 and year 3 afterwards. That's the first part of your question, I guess. And then we have the other part, which is more related to staging. Yeah. Basically, in all women with dense breasts, we use MR for breast cancer staging, because most of the time we feel that we do not have a clue how big the cancer actually is. If women get over an age of roughly 70, 75, sometimes we think that the life expectancy of these women is relatively low, and finding any additional cancers will not change anything in the life expectancy or in the way we would treat them. Obviously, in these women, we forego the MR, right? There's really very little use for it. In most people where the aim is to treat them optimal, we do both. We do this in any case. And I've long been talking about pre-operative MR. And honestly, I really think that term is a misnomer. It should be a sort of a pre-therapeutic MR, where the goal is to basically figure out how to treat a patient, because you do not know from only the memo. So with that in mind, we hardly ever devise a treatment plan before we actually do have the contrast images. And I do agree with Julia, if you can't do the MR, then contrast memo is sort of a decent alternative. It's definitely better than nothing.
Thank you. Tá fechado seu microfone, Pasqualette.
Vamos dar prosseguimento. Eu queria que vocês fizessem uma pergunta para cada palestrante, porque nós temos um tempo que estão me cobrando muito aqui. Tá? Eu queria chamar a doutora Júlia, que é presidente da Sociedade do Rio de Janeiro, e depois a gente chama o Rodrigo Pepe, que é o vice-presidente da Nacional, para fazer suas considerações. Por favor, Júlia.
Bom dia a todos, muitíssimo obrigada pelo convite, obrigada Henrique Couto, é um prazer poder participar desse evento que é um sucesso. E Henrique Pasqualette, obrigado pelo carinho e pela apresentação, mas vamos direto então à pergunta. A minha primeira pergunta é para a doutora Júlia. Gostaria de saber se existe a nomenclatura, a porcentagem, se a gente pode falar em overdiagnosis, com mamografia contrastada e falsos negativos, vistos que a gente sempre tem a mamografia de baixa energia para fazer a comparação, e se diante de algum achado adicional, há indicação, por exemplo, de uma ultrassonografia second look, como nós fazemos nos achados de ressonância magnética.
Well, what's been published in the latest meta-analysis, the Dutch one actually, is that the negative likelihood ratio of MR is like 3%, and that of contrast-enhanced mammography is 5%. So it's better for MR is better. The positive likelihood ratio is similar. It's around 4% for each of them. So that means that, yes, if you will see false positives, and then you will have to go on to second look ultrasound, and if you don't see the lesion and it's suspicious enough, and you don't have contrast enhanced mammography guided biopsy, then you will have to go on to MR guided biopsy. Did that answer your question?
Ok. E uma pergunta para o Dr. Mann, se ele usa a difusão na sua sequência de exames, principalmente, por exemplo, num caso de um carcinoma in situ extenso, se a difusão acrescentaria na possibilidade, na probabilidade de avaliar uma área invasora nesse tumor, através da difusão na ressonância.
I do run diffusion. Let's start with the first, right? Most of the time, I think diffusion is mostly useful when lesions are relatively big. Nonetheless, if you would have, for example, DCS, you will see that there are areas within the DCS that might have more diffusion restriction than others. If those correspond to the area that has been biopsied, you might actually be looking at the hematoma, but if they're away from the area that you have been biopsying, that might actually be hinting at the potential invasive focus. And as such, it makes sense to actually incorporate it due to the simple fact that it will maybe focus your vision a little bit more on an other part of the lesion. I actually make diffusion next to the contrast enhanced series, not so much for the evaluation of the primary tumor, but mostly for eventual classification of additional lesions in the breast. Right, you will find incidental fibroadenomas and so on top of the cancers that are there, and actually being able to state that it's a fibroadenoma without having to do another biopsy is a nice thing.
Muitíssimo obrigada. É um prazer estar aqui. Muito obrigada. Parabéns.
Ok. Rodrigo, vice-presidente da Sociedade Brasileira de Mastologia, por favor, suas considerações.
Bom dia, pessoal. Agradecer o convite do Henrique Couto, da comissão organizadora, por poder estar aqui com vocês. É interessante a gente assistir essas apresentações, Pasqualette, porque nosso objetivo é sempre diagnosticar mais cânceres de maneira mais precoce para que a gente possa oferecer um tratamento adequado e melhor qualidade de vida para os nossos pacientes. E é interessante, a gente que trabalha com imagem, quando a gente viu os trabalhos de tomossíntese, vê os trabalhos de ressonância e também os de mamografia contrastada, o quanto que a gente perde diagnóstico de câncer fazendo somente a mamografia. Isso dá uma angústia quando a gente olha para trás, nossos laudos de alguns anos para trás, para caramba, eu perdi muito câncer fazendo somente a mamografia. E a pergunta é assim, a nossa sociedade aqui, com essa última resolução, já colocou a tomossíntese como uma grande possibilidade de exame para rastreamento, sociedade americana e europeia da mesma maneira, e agora a gente vê ascensão ou mais estudos a respeito de mamografia contrastada. Então, a pergunta é, a gente tem medo de fazer rastreamento com exames de contraste, mas a gente pondera sempre, a ressonância já é uma realidade para a maior parte das pessoas em termos de rastreamento de alto risco. Será que não é hora da gente começar a pensar em fazer um rastreamento com contraste, mesmo com a mamografia contrastada? Será que ela tem espaço somente para os pacientes de alto risco, como a doutora Júlia colocou, ou será que ela tem espaço na população em geral, pacientes com mamas densas, de um modo geral? E para o doutor Ritse, eu gostaria de perguntar, a gente tem muito problema com a ressonância em relação aos falsos positivos. Ele mostrou um caso bem interessante, onde a mamografia mostrava uma lesão pequena e a ressonância mostrava uma extensão maior dessa lesão. No serviço dele, na prática dele, é imperativo que se faça a biópsia dessas outras áreas que foram vistas na ressonância, ou está autorizado a partir direto para a cirurgia somente com o diagnóstico por imagem, sem a histologia comprovada dessa área mais ampla?
Okay, regarding screening with contrast enhanced mammography, I would say that we would have to run some artificial intelligence tests first and stratify the patients. When we talk about general population, although we are doing screening in patients with a history of breast cancer, and that's thousands of patients, they're not few patients, it is feasible, but still, when we talk about populational screening here in Europe, we do it to every woman from 45 to 69, depending on for 50 to 69. And the age is going to be upgraded, so to speak. It's going to be till 74. We need some method to stratify these patients. And regarding high-risk screening with CEM, I would definitely do contrast MRI, because of what Ritse showed you. I mean, the use of ultrafast has changed so much the way we scan young women. We don't have to bother about background parenchymal enhancement anymore. And I think high-risk patients deserve the best method that we have, and that is MRI.
And I can follow on that, I guess. I do agree, right? High-risk screening should be MR. And at some point, contrast mammo may come in as an alternative. And then predominantly, if we bring contrast enhanced screening to a wider population, simply due to the fact that we do not have the machines nor the capacity to actually offer MR. Considering the staging question that you asked, there's two different approaches to that. One is, it's very, very obvious that what you look at is one tumor. In those cases, I will not take no for an answer from our pathologist, right? So in that case, it doesn't really affect so much what's going to happen. And then there is the cases, the more non-mass enhancement, for example, that could also be peritumoral inflammation to think of, or a separate mass that's really different in its appearance from the primary lesion, or a separate mass in an additional quadrant of the breast, or even completely on the opposite side of the breast. That would have a major impact on the potential type of therapy later on, and actually might also disappear as snow for the sun under chemotherapy, and then still be a cancer that you should have needed to treat also differently. So I would not say that you always need to pursue histopathology, but in many cases, if there is really an impact, or you are not sure enough of your diagnosis, make sure that you do. Otherwise, you get unnecessary mastectomies. That's something that we definitely should prevent.
Bom, excelente palestras, realmente foi um ganho muito grande. Eu queria agradecer a presença de todos, a intervenção de todos. E dando prosseguimento ao evento, eu queria apresentar o próximo coordenador do terceiro bloco, o Dr. Henrique Silva Bardel, médico mastologista, graduado e pós-graduado pela Universidade Federal de Minas Gerais, mestre e doutor em patologia mamária e chefe de clínica do Hospital de Mastologia do Hospital da Polícia Militar de Minas Gerais. Muito obrigado a todos e nós vamos continuar com esse evento maravilhoso, com muitos ganhos científicos. Obrigado.